You're listening to the EndoCast, a podcast about all things endometriosis, with your hosts, Britt Thelman-Pangrel and Dr. Eric Heegard. Hey guys, good morning. It's Britt, and I'm here with Dr. Heegard. How are you today, Dr. Heegard?
I'm fabulous. I'm especially fabulous because I'm here with you, and we're talking about important stuff.
Very important things. Today we're going to dive right into surgery, which is one of your expertise areas, and I'm excited about. So I guess when a new patient comes in, obviously you have kind of a protocol. Can you kind of just walk us through the process of when you're interacting with a brand new patient and maybe how you decide to go down the surgical route or how you decide not to do surgery right away?
That is a great question, Britt. And there's a couple things that I always try to keep in mind when I'm talking to somebody who's new or even somebody who's not new. And the question is, I guess in my opinion, when you're talking about treatment, you're always talking about what is the goal,
right? And
what are the risks and benefits? Because
sure.
And over time, and given somebody's personal history, that I call it kind of my own risk ratio of, can change, and somebody's goals for treatment may be different too. So, and I know we've talked about this before, but if you look at endometriosis, it causes kind of two main things, umbrella sort of issues. One is fertility, and the other is pain. And sometimes people may not necessarily have so much pain, but they're struggling with fertility and that sort of thing. And so you're trying to figure out what the goal is.
Yep.
And so that's where you want to sit down and really have some time and talk to somebody and figure out where are they trying to get, because you don't want to do something that may complicate their fertility if you don't need to. And so the other thing is just a person's underlying risk. If there's somebody, if they've had a lot of surgeries, if they have underlying medical issues, for example, heart disease, diabetes.
Well, you even like to say endo, and so many people with endometriosis have other conditions too.
Right. And again, that's a great point. I had a conversation with a patient recently where we're talking about operating, and I felt uncomfortable about what the possible benefit would be given other stuff going on. And so, which is a hard conversation to have. But so you sit down with the patient and you sit down and you talk, and it's a dialogue, at least from my perspective. I try not to be very top down on this. You sit down and you just try to figure out what the goal is and what the risks are.
Sure. So what are some questions that you might ask a patient to help you determine that information?
Well, and hopefully, I guess the most important, or the way I start, is what has been done so far.
Okay.
So if somebody comes in and they've got pain, for example, and they have tried multiple different courses of medical suppression, birth control pills, that sort of thing.
Sure.
Then I am more inclined to kind of take the next step, and also the severity of their pain, and so you go through a kind of elaborate process of talking about when somebody has pain, what makes it worse, what makes it better, and so those are some of the first questions that I ask about, and hopefully, and I know we may talk about this later on, but the idea of somebody bringing in their records so we can kind of go over that together, and we kind of start there.
No, I know before my surgery, but granted, I was significantly older. I know some patients you get are teenagers or in college, and I was about to turn 30, and I brought in 9 pages of handwritten notes and 15 or 12 years of medical history and ultrasounds. I mean, that's ideal, right?
Right.
More information, the better.
Exactly. And so you can, because you want to, especially when you're talking about surgery, and I've said this to many people. I know that other people who kind of specialize in this area feel the same, which is you never know what you're going to find till you're in there.
Right.
If you're especially if you're the first person, and sometimes even if you're the third person. And so you try to imagine what you're getting into before you get into it, because you got to decide what kind of team you're going to put together. You can't, sometimes you end up having general surgery or colorectal surgery, urologists that specialize in the kidney and the bladder and that sort of thing. And you really can't without really agitating your colleagues and adding significant cost to everybody, invite a whole team of people for something you think you may not need them for.
Sure.
And so you just to try to take good care of the patient in many ways, and is you want to try to imagine what you're going to need and set up the appropriate team.
Okay. So if we're thinking, you're in the evaluation process and you're meeting with patients, how do you know when surgery is the right next step, or who is a great candidate for surgery in your opinion?
Again, there's no right or wrong answer there. Again, it's a matter of sitting down and figuring out with the patient what her goals are. Is it somebody who's been trying to get pregnant, who has been unable to get pregnant, and has tried everything else?
So why is surgery a great option for those candidates?
Well, because right off the bat, it's been shown that roughly about, if you walk into an office with trouble getting pregnant, it's almost a 40% chance that there's probably some endometriosis in there.
Yeah.
Even if somebody doesn't have symptoms, unless there's some other obvious source for it. If the husband doesn't have any sperm, if the woman never ovulates, if there's something, that's kind of easy. But if somebody comes in and the basic underlying, you take a history and she's ovulating, there's no reason to suspect that her tubes are blocked, and the husband's semen analysis is fine, and there's no other medical underlying reason for it. You can, there's, at least a 40% chance that there's probably some endometriosis in there. And so again, you're trying to figure out, whether, what you're trying to get out of it. And so there's been studies that have shown that if you can go in and excise endometriosis or ablate it, frankly, and the studies are kind of old, but that it can improve spontaneous pregnancy rates and success. So that's a situation where you'd want to offer that to them.
So that's when you might lean towards surgery a little sooner,
right,
when you're meeting that patient. All right, so let's go on the other side when we're talking about pain. And I know pain is so complicated when it comes to endometriosis. Right. When do you decide, because of someone's pain, that surgery is the right next step?
Well, again, from my standpoint is that by the time usually I've seen somebody, they've tried a lot of the other stuff. They've tried, virtually everybody gets started on birth control pills and that sort of thing if they have heavier painful periods, and if those aren't working and their quality of life is not where they want it to be, then as long as they're a good surgical candidate, I think the next step would be to operate.
Okay. Yeah,
and because you're trying to relieve their suffering in one way or the other, and if the easy stuff hasn't worked, I think that's the next reasonable step to consider.
Okay, so you were talking about knowing when to bring in a team. How do you know? Because endo, that's what's so unique, as we've talked about, is that endo is a very interesting, complicated, and kind of a bitch of a disease. It doesn't just appear in the pelvic cavity. It can appear, I hear about it a lot more on the diaphragm and in the lungs and that thoracic endo, and obviously a lot on the bowel and the colon. So when do you know when to bring someone else in? Because I think that could be really difficult.
Right. It is. And so that's where sitting down and talking to somebody.
When I mean someone else, I mean another doctor, like a specialist in another surgical area.
Exactly. Yeah. And so when you're talking to somebody, you can often get a sense, even if they, obviously if they've had surgery before and somebody's taken pictures, and that can be helpful to see what you're getting into. But oftentimes you can get a sense of it by just talking to somebody and doing an exam. A lot of times pelvic exams and sometimes just physical exams in general are not as helpful as you'd think.
Sure.
That's why when you go into the emergency room, a lot of times before they even see you, they've already determined they're going to get an ultrasound, a CT scan. They kind of go in and feel around and make sure there's nothing obvious. Well, pelvic exams can be, in some ways, a similar thing, which is in somebody who doesn't have a lot of symptoms, you may not find much, but I think an exam can be particularly helpful for me with somebody with endometriosis. And what I'm looking for are specific things.
Uh-huh.
One is I'm feeling for, is there nodularity? Like, do you feel the uterus tipped backwards? Is the uterus, mobile?
Mobile.
Moving, if the tissue
is your uterus mobile?
Yeah.
Because that's a good thing.
Yeah. Let's start out with that question, shall we, madam? Is your uterus mobile? And so those are things that can tip you off. So, for example, if you feel like the uterus is, tipped back, oftentimes that can suggest that it's perhaps kind of stuck to the rectum.
Sure.
If you can feel nodularity behind the cervix, because usually you can feel little bumps, and it's exquisitely tender.
Okay.
And I usually don't do rectal exams unless I really feel like somebody needs it for a lot of reasons. I almost hate doing them as much as somebody hates having it done.
Yeah.
But
I didn't know you were going to take us there today.
Well,
I'm like, oh.
Yeah, it's just, but you can't, one of the things that, again, if you're suspicious, if somebody has rectal bleeding, if, for example, that you want to make sure that the tissue between the rectum and the vagina and the back of the cervix is smooth and movable.
Okay.
And it can be helpful. So again, the physical exam can help you decide, okay, well, I think, there's a chance that there could be something in that on the rectum. And in which case, without even getting an MRI or an ultrasound, you start to think. And this is this process of actually thinking instead of just kind of knee-jerk ordering tests.
Sure.
And then there's imaging studies and ultrasound and MRIs, which I don't use a lot of. But for example,
why not?
They're very expensive.
Okay.
And I don't mean, it's, you don't want to think that it comes down to expense, but it's whether you think it's going to, because it can be expensive for patients. It can be very expensive, and they take a long time, right, compared to an ultrasound. Some people just, have you ever had an MRI, Brett?
Yeah, I hate it. I have to take drugs.
Yeah, you're sitting
and
there.
It's like of your lower abdomen, and they put me in head first.
Yeah, you're sitting there in
It's like the worst
tunnel.
Star Wars ride, and they don't talk to you. At first, the guy was really nice, and he's like talking to me the whole time. And
then you run
about
out of things to talk about.
Yeah, and then it's silent, and all you hear is like the buzzing and the beeping and the
clanking
lights
and stuff. And so it's
take a Xanax first.
That's a good point. So that's why oftentimes we don't jump to that. But an ultrasound for many people can be very helpful.
Sure.
And again, you can see certain things, which is, as the uterus you can see it sometimes bent back.
Okay.
Literally like
Folded almost?
Yeah, folded back, like somebody's taken it and just kind of used their hands and kind of, compressed it. And that is really, when you see something like that, especially if somebody's got symptoms that are suggestive of pain in that area, I mean, in the rectovaginal area, then you got to, that's someone, I don't care what the MRI shows. A lot of times in somebody like that, I probably would get an MRI. I would go ahead and have somebody available.
Assemble the team.
Exactly. Assemble the team. And some people, if they have bleeding and symptoms like that, I oftentimes will have them get a colonoscopy.
Yep.
And again, if the person doing the colonoscopy, sees something that is suggestive, well, then of deeply invasive penetrating endometriosis into the rectum. Yeah. Or sometimes they can tell that the rectum is not mobile, it's not movable, or it's getting compressed or going in a weird way. Again, you start to think, okay, there's something more in there than what I suspect.
Well, a friend of mine had a colonoscopy as part of her surgical workup, and they thought she had colon cancer because of how the colonoscopy came back, and they saw a bulge or something, and turns out it was endo infiltrating the rectum.
Right.
And she had to have a bowel resection as part of her surgery.
Right.
She doesn't have one of those, what are they called, the bags?
Colostomy bags.
Colostomy bags. She didn't need to do any of that, or a stoma or anything.
No.
But then, in her surgery, she did have, I believe, a bowel specialist and a rectal specialist.
Right, exactly. So, and you can't always, oftentimes you just don't know what you're getting into until you get in there.
Yeah.
And so, but sometimes you can, and you want to ideally have the right people in there to try to take care of it at that time if
Be
you
the
can.
most prepared.
Right.
I guess that would make the difference too in preparing for surgery, because some people complain about the bowel prep, but I didn't need to do that.
Yeah.
So.
Right. That's not a pleasant thing, and people have different feelings about it. And I pretty much, and this is just my own personal perspective, and I pretty much bowel prep almost everybody. But there's been studies that, and people feel differently about it. If you're not really worried about it, you're not concerned that you're going to have to do something on the bowel. Bowel preps are kind of yucky.
Yeah, but I bet you feel really clean after.
Clean as a whistle. Yeah.
Okay, so go back to surgery for infertility, because we've had a lot of questions in the private Minnesota Endo Warriors Facebook group lately about, infertility is coming up a lot, and people are talking to their gynecologists who are not endometriosis specialists, so they're not Nook doctors, as we like to say from Nancy's Nook.
Yep.
And this one person in particular said, well, my doctor won't refer me to an endo specialist because he doesn't think surgery is the right next step, because he's pointing to studies saying that surgery on your ovaries in particular can actually be detrimental.
Right.
So when do you make that determination that surgery and working on the ovaries in particular, like if there's an endometrioma or if there's tissue or adhesions, when that's the right step to support infertility and when it isn't?
Right. Again, that's a very nuanced question about a very nuanced area.
Know.
And I will tell to our listeners that we are going to talk about the infertility we're going to do a deep dive on that in further episodes with probably a subspecialist in this area. So I don't want people to think that we're not covering it to the extent that we need to, but the issue again would be what is the goal? Is it pure fertility?
Okay.
Because if somebody doesn't have pain and they've got something like an endometrioma, which is a cyst on the ovary that has endometriotic or has fluid in it usually, and it's got a very distinct appearance, which you can basically look at that. This is the gold standard of diagnosis, as you know, is laparoscopy, to look in there to make the diagnosis.
Oh, you're right, to make the diagnosis.
But you can pretty much, even without a laparoscopy, you look at those things and look at somebody's symptoms, you can pretty much just say this is endometriosis.
Okay.
And so, what you don't, if you're talking about treatment for fertility, then you got to make that decision, which is this going to be helpful or not? Because endometriomas in themselves are, especially if they're not painful, it's hard to know whether that really is contributing much to their fertility, because the presence of endometriomas oftentimes signifies other endometriosis in the deep pelvis.
Oh.
And so the very presence of the endometriomas may not be adding much more than the underlying endometriosis there. And the worry is that if you are operating on the ovary, if you try to, depending on the technique, but even if you're doing everything with the best technique, there's a possibility that you may affect what we call ovarian function. Mm-hmm. So you got to be careful about that. And so, what is your goal? What are your goals? And what are the symptoms? And so, the big question with fertility that I get asked periodically is like, I'm going to go to IVF now. Should I go ahead and have surgery?
Right.
And that's really debatable. Most people,
case by case. Yeah,
most people don't generally operate. If somebody says, "Okay, I'm going to IVF, but I think I've got endometriosis. Should I have the endometriosis taken out?" Most people would say probably not. And with IVF, because the studies are not very conclusive as to whether cutting out the endometriosis really improves IVF outcomes. Now,
because you're taking so much of the body's portion of that out, like you're not worried about ovulation necessarily,
Right.
because they're going to stimulate that.
Exactly.
And you're not worried about them traveling through the tubes and getting stuck or anything,
Right.
because you're going
You're
to
gonna
bypass
bypassing
that.
Right.
And you're not worried about inflammation blocking sperm, because you're going to bypass that.
Right.
So that makes sense.
Where I have, where I have chosen with the patients, obviously, discussion to operators is something. For example, I had a patient that had done 2 courses of IVF and it failed.
Okay.
And
that's expensive.
And she had 1 egg left, one good high quality fertilized embryo,
Yep.
frozen embryo, and they were and they weren't sure whether they were gonna, if this didn't work, whether they were gonna try again, and so it was, and that was a situation where I felt pretty comfortable. Like, let's go in and see if we can clean things up. At least if it didn't work, then you can say, well, at least we tried, and it did work. And so you don't know whether it's at least you don't, at that point you're thinking, wow, I'm that good, but you don't. But you don't.
You're so humble.
Yeah. Well, no, I'm kidding, of course, but it's the reality is you don't know whether it's just total luck.
Sure.
Because there's an odds aspect to everything, and if you roll the dice enough times, you're going to nail it. And so they may have gotten pregnant either way, but
they say that isn't insanity the definition of insanity is doing the same thing
Right.
over and over and expecting a different result. So
right.
if they were going to try this 3rd time, do something different,
Right.
and she had surgery and
exactly. So it very likely it could have just been the odds, but it makes some sense. Like we were talking about studies that have shown that, especially we're talking mild and moderate, or mild endometriosis, minimal and mild, that if you go in and operate, and that is, those studies were either excision or ablation,
Okay.
and ablation is, just using electricity to kind of burn it off or whatever, that it improved pregnancy outcomes. And if you talk about why endometriosis can affect fertility by the underlying inflammation, the stuff that, we know that the fluid that kind of lubricates our bowels and the pelvis is different in women with endometriosis than in people who don't have endometriosis.
Mm-hmm.
And that fluid is going in and out of the fallopian tubes and into the uterus. Endometriosis can cause anatomic distortion. It can stick the tubes to the sidewall and the ovaries, it can. And so there's a lot of reasons why you can see why endometriosis would affect fertility.
Sure.
And so if those studies have shown that, at least with minimal or mild, that there's improved outcomes, it sort of makes sense that if you can free things up and remove some of the stuff that's causing the inflammation, that it could improve outcomes for things like IVF. And so I think it's something to consider, although I think it's still kind of debatable. I think if you talk to most people, they wouldn't say, well, go ahead and then operate if you're doing IVF. Now,
Right.
If you're not doing IVF, if you're just in the, in the big beginning processes of trying to understand what's going on, and you're pretty confident that they have endometriosis, and IVF is not something that they want to jump into, which most people don't, then I think it's reasonable to go in there and cut it out.
So what I will say
That was
to
a
that,
long-winded
no, that was good. I feel like that was really good. What I will say to that though is, if at least in the state of Minnesota, fertility coverage is not mandated.
Yeah.
And if you have surgery for fertility, expect to pay for it out of pocket. At least here.
Well, that's why you got to be. But people usually have other symptoms of, like
So that's
painful
what I was
periods or
gonna
heavy
say.
periods, and
But you need to make sure your doctor is coding it that way.
yeah,
And I think that can be a real big game changer for people when I don't want to say counseling, but maybe.
Yeah.
And now I'm thinking really highly
You
of
do.
myself.
Yeah.
But when
I know you do. You're an educator.
But when I'm counseling someone before surgery and we're talking about infertility, I always say to them, I'm like, make sure your doctor knows that fertility is one of many symptoms that you have, or
Right.
infertility. And when you're in that appointment, don't just talk about that, because they legally have to code the appointment, or the coders, the medical coders, read the doctor's notes and they code it based on what you talk about.
Right.
So make sure you're talking about your other symptoms. But ideally, I mean, that's how I got my surgery covered. Yes, we were in the infertility, we were headed down that road, but my pain was so
Right.
bad, and I wasn't functioning at work because of the pain I was in, that it was an easy, okay, this
Yeah.
is for pain. But my insurance company even said to me, if you're having this surgery for fertility reasons, it's not covered. But if it's for pain, even though it's the exact same surgery, they're going to do the
Yeah.
same thing. So just a word to the wise, like Britt, hot tip. If you're headed in for
Yeah.
this kind of stuff, just you will thank me, because the surgery for me, my case, I mean, was more than $15,000.
Yeah.
And that was not something I could have just handed
just written
over
a
out of
check, yeah.
pocket. Yeah.
Right. And so so this is where the surgeon and the patient can work together, because it is important as somebody on the provider side that you're honest, and you don't
No,
want to.
of course.
Yeah, I know, because just in terms that you need to be honest with why you're doing things, but that doesn't mean you can't. Again, if somebody's having pain or heavy menstrual periods as well as fertility, that is being forthright with what you're doing.
Right.
You certainly wouldn't want, at least from the provider standpoint, if somebody wasn't having any pain, it would be hard to justify.
No, I respect that. I'm not talking about fraud here.
Thank you.
No, I agree. Okay, so that's like when you do surgery to support fertility.
Yeah.
Now talk to me about when you've determined someone's pain is at the point, or their periods are so heavy, how you decide to do surgery.
Well, again, what is our goal and what are the risks? And so that is, and for most women with endometriosis,
People,
thank you.
I like to
people
keep
with
you gender neutral.
Yeah, no, thank you, Brett. What did we talk about with
people with periods?
People with periods.
Mm-hmm.
That, most of the time, I can't remember what was the question. Yeah, sorry.
When you're choosing to do surgery.
Can we stop that? Okay, go
Yeah.
back. When you're choosing to do surgery.
For pain, to help someone with their pain.
Yeah, so should we just go back and redo that, Twyla? Or should I just keep interrupting and saying Twyla? Okay, Jesus, Twyla, we're already. All right, so say it again.
So now that we've talked about the infertility side of surgery, tell me when you know it's the right choice to help someone with pain. Surgery is the right choice for you.
Right, and so we talked about this a little bit before, which is why are you doing it and what are the risks, and so you need to sit down and talk to somebody about that, and depending on where they are in the process, if they've been on medical treatment or medical management of their symptoms and those aren't getting better,
AKA hormones.
Yeah, usually like birth control pills and that sort of thing, and there are others. I mean, we can talk about that in different shows, but then I think the next thing to do is to consider taking a look, and surgically, with the idea, and then you want to talk to the patient about what is our goal there. Are we going to go in there and just look and take pictures and come back and fight another day, or do you?
No.
Right. I'm saying that was.
I hate that option.
I threw that out just to agitate you.
I could tell.
But most of us would ideally, and both providers and surgeons and the patient would rather you go in there and do something to try to improve their symptoms, not just go in there and look around. And so that's when you decide to move ahead.
Okay, so yeah, I was gonna say, that's an expensive peak.
Yeah.
I mean, I just want everyone to know, if they do a laparoscopic procedure and I don't want to say slice and dice, but it's kind of fun to say, because the incisions are really small and you've got this camera. Tell me about the machine. Do you use the Da Vinci robot?
I do.
Okay.
Yeah.
So talk to me about those incisions and where they go and why you put them there. And
Well, and before I go into that, I use, especially for people with, I'm operating on for pain specifically, and I think they've got endometriosis, I do tend to use the Da Vinci robot.
Okay.
Which is really a better way to say it, and is maybe robotic assisted laparoscopy. That being said, so that is not necessarily, that's not the standard around the country, and there are people who use the robot, and there are superb and some of the best in the world surgeons who just do it with straight stick laparoscopy. And
straight stick?
Yeah, that's what we talk about with, just laparoscopic tools that go in that are not robotically manipulated. And so there's no real advantage. You can't really say, well, robotic assisted laparoscopy is better than just regular laparoscopy. It has nothing. It really has to do with whatever the surgeon is comfortable with.
Yeah.
And everybody's, it's kind of interesting. You would not believe how many people do the same surgery in different ways.
Mm-hmm.
It's like heirloom tomatoes, Britt. There's like 50 million heirloom tomatoes, but they're all tomatoes, right? There's like you talk to 50 surgeons, and they will approach the same thing with subtly different ways, with different tools, and it's kind of what they're comfortable and what works for them. And so I just want, before I jump into that, I just want to say that there's, just because I use the robotic assisted laparoscopy doesn't mean it's better. It's really the experience of the surgeon and, their skills and what makes them operate to the best of their ability. And so, but yes, so your question was, where are the incisions, how many? It just kind of depends. Usually there's 3 or 4 little incisions.
I have 4. You want me to tell you where mine are?
Sure.
Okay, so there's one in my belly button, and then I have one on like either side of my belly button.
It's actually pronounced belly bouton.
Oh.
In French.
You're
belly
a dork.
bouton.
And then I have one kind of, and you guys can't see me, but I'm literally touching my stomach and like pointing. Yeah. And then there's one lower kind of more on my like bikini line on my right side. Yeah.
So it kind of depends on what you find. Usually I shouldn't say usually. You get in the initial camera.
Okay. So where does the initial one go? It
depends on it depends on the person. So a lot of times we will usually put the camera in the belly bouton.
Okay. All
right. I'm kidding, of course, belly button, or the umbilicus or umbilicus. As I say. I love these.
I know you love a good
pretentious. These we're going to put the camera in the umbilicus, just so you sound like you're smart.
And if people really knew you, they knew that you're not pretentious. But now you're just really turning it on for
this podcast. We shall put you in the Trendelenburg position and put the initial camera through the umbilicus.
Okay, so it goes in through your belly button.
It does, and so most of the time you do that, and there's a lot of reasons for that. Number one, that's where you usually have the camera port. So one of the incisions, you need to have a camera so you can see what's going on. Yeah. And that's usually,
otherwise you'd be operating
blind. Blind laparoscopy is not a good idea.
Yeah. I think this is an ovary.
Yeah, it feels like it. Using
robot.
Using echolocation, I've determined that your ovaries are there. So so you're going to put the camera in somewhere, and then just cosmetically, that's a good place for it because it heals up and most people can't see it. And then that's just a good place to have the camera in terms of what you're looking for. And then, but if somebody's had a lot of surgeries before, if you suspect there could be scarring or what we call adhesions, then a lot of times we will put a camera in, at least initially, in another area.
Okay.
Oftentimes up in the left upper quadrant. So under the ribs, 3 centimeters called, you know what that is, Britt?
No.
The Palmer point, which is not it is not named after
one of your favorite
one of my
specialists?
exactly, Dr. Matt Palmer here in Minneapolis, St. Paul's, is a superb surgeon and a wonderful human being. But I think the Palmer's point has been around for
he just got
50,
lucky.
70 years. But that the reason why going in there for many people is helpful is that it's been determined over time that that's one of the areas of the abdomen that tends to have the lowest chance of having scarring. Okay. And so it may be the safest way to go in. So you may put the camera in there to see what kind of do an evaluation of, put it in, look around, see where the scarring is or not, is not, and then you kind of put in your other ports.
Okay, so you're putting in all these tools, the camera, and then you've got your surgical tools that go in there with you. And then, is that when you inflate the abdomen too? Because I know that you need to puff that up and put some air in there so that you can see things, because things are all kind of laying on top of each other and compressed.
Yes. Yeah. So there's different ways of doing that too. Some people use what's called a Verey's needle, which is you just kind of put a small little needle through the abdominal wall into the cavity, and then blow up the abdomen like a balloon.
Okay.
And then they put their ports, put the actual little tube that holds they look like, they're kind of almost the way when they're being instrumented or when they're being put in, they look like almost like a pencil, which is they're round, and then at the tip there is a tip that is to varying degrees of sharpness, and so that allows to kind of push in through the abdomen or through the abdominal wall and into the abdominal cavity. And so, but then you take that little tip out so it's not dangerous.
Okay.
And so that's how you. And so then you can some people usually at that point you've had the belly blown up and then you're popping that in. Some people will just put the camera in directly.
Okay.
So without putting a Verries needle in first, and you can and this is kind of cool. There's different types of what we call trocars, which are those tubes that you put in, because you got to be able to put instruments into the abdomen.
Right.
And so you have this little tube, and there are trocars that allow you to look with the camera as you're putting it in. So you are actually, you're actually seeing the tissue underneath where that trocar is as you're pushing it in. So you can go layer by layer, fat, fascia, which is connective tissue, then muscle, and depending on where you're on
peritoneum,
into the and then you can see it open up, and then you insert the gas at that point.
Okay.
And, yeah,
that was very visual.
That was a gassy answer.
Yeah, but I feel like we could have been on a Magic School Bus episode with that one. Like
with Miss Frizzle?
Yeah, totally. Actually, we should call them and see if they want to do one on endometriosis. Yeah. That would be so cool.
Miss Frizzle, how do you put in a trocar?
Yeah. Well, kids. Today. Okay, that is so.
That's more detail than maybe people want.
No, but I think that it's important to know that if you're having any kind of laparoscopic procedure, you're going to go through those steps. So you haven't even touched on the fact that what do you do when you get in there and how that's different, and we're going to talk about that in another episode and dive a little bit deeper into the different types of surgery, etc. But
are we going to do a deep dive?
Yeah, why not?
Why not?
But I think it's important to know that if you're signing up for surgery, this is a major abdominal surgery. You're going all the way under.
Yeah.
It all starts out the same with these same incisions, basically, depending on where your symptoms are or what they're trying to address. So that's why my recommendation, and I think you would agree, is to try to find someone who can do something about the problem.
Right.
Rather than just go in and look, do something about the problem. Now, you want to make sure
that would be ideal.
Yeah. But you, like we said before, if you can't, make sure that your surgery includes a camera, number one, because otherwise they'd be operating blind. But number two, when they're in there with that camera, get pictures, get video, and then send them to a specialist later. Or
just bring, a lot of times, you can bring them with you, and it can be really helpful to look at these pictures if they're high quality and say, oh, yeah. Because, people who have done a lot of this, and there's a real experience or experiential kind of aspect to this, where you can just, look at the pictures, go, oh yeah, that's endometriosis there, that's it there, and may have been told that it was completely normal laparoscopy. Yeah.
So what I would say about that too, because we talk a lot about, or we try to say, don't be afraid to fire your doctor, or don't be afraid to get a second opinion.
Yeah.
If you're to the point where, and sometimes, in my case, I was to the point where I was asking for surgery.
Right.
If you're to that point, do it. Find a skilled person.
Right.
Remember, there are reviews on the internet. You can use the internet.
Yep.
Feel free to use Nancy's Nook or the Minnesota Endo Warriors. If you're here in Minnesota, we list the specialists and we work with them. But Nancy's Nook, Endometriosis Education Nook, on Facebook, has a list of specialized surgeons for endometriosis around the world.
Yep.
If you can't get in with one of those people, which Dr. Hegard is one of those people.
And I feel very privileged to be on there.
I know.
I'm going to,
yeah, they do a great job, all of those admins. And if you can't get in with one of them, at least try to find someone who has a good surgical track record, great technology, and can get some good pictures. And if you wake up from surgery and they tell you don't have it, get those photos, get those images. And maybe seek a second opinion, I think. If you're still having all this pain or this unexplained infertility, and you already have the surgery and you already have the images, what is one more doctor to look at?
Right, exactly. One thing I want to just circle back to for just a second, because you were asking how do you set up your team, and you had mentioned thoracic endometriosis, and we didn't really talk about that very much, but again, that goes into the history when you're talking to somebody. So, for example, if they, may have, when they get their period, they get upper abdominal pain, and maybe they cough, or maybe they, it's painful to breathe.
Yeah.
That's when you start thinking, okay, could there be something up in the upper abdomen? And then, again, we're not going to call in a thoracic surgeon for that at that point, but you'd want to be prepared to ideally address that during surgery, which is, often, and everybody does this different, but I would probably have a laser available in that situation.
Okay.
And so you're looking.
So I guess your point to that too is, just make sure you're telling your doctor everything.
Right.
Because I think that can be difficult. I know we have an episode talking about sex too. Make sure you're sharing all of your everything with your doctor. Yep. That's also why it can be hard to change doctors.
Right.
So telling them all the symptoms, just because you don't think it's related because it isn't pain around your period doesn't mean it isn't. So let loose. If you are having shortness of breath or chest pain, or other bowel issues or pain with sex, like those are all really important features to your diagnosis, like that your doctor needs to know about. So yeah, that can really help you determine if you need a team in surgery, how extensive your surgery might be, etc.
And be honest with your doctor about your medical issues. And I've had situations where somebody really wanted surgery, but they kind of did not disclose underlying other medical issues that I think they suspected would kind of, and once you find that out, then it's hard to kind of, you feel like there's a bit of a, I don't know, you
breaking
don't know
the trust
a little
tree.
bit, yeah, because you're putting, if somebody's got underlying medical issues, and you can't always get all the information you get. So if somebody's got an underlying, significant medical issue, like kidney dysfunction or whatever, operating could be very dangerous. And I can understand why people want surgery, but sometimes, again, it's always a risk-benefit
I love
thing.
it. Yeah, that's important. Be honest. Be thorough.
Right.
Excellent. Well, thank you so much for giving us that deep dive today, Dr. Hegard.
We didn't even talk about excision versus ablation.
We're going to have to. I think it means we need to do another episode on surgery.
Yeah.
I also want to talk in a future episode about preparing for surgery,
right,
and helping people prep, since we feel like that's really common, and post-surgery too. So make sure you guys
sounds good.
Stay tuned for that.
All right. Thanks for listening.
Thanks so much for listening. Be sure to connect with us on Facebook at facebook.com/The Endocast. Our theme song is Renegade Energy by Tacky Annie. This is a Matriarch digital media production. Learn more about Matriarch and check out all their great podcasts at matriarchdm.com.